Good afternoon. My name is Jonathan Swanson. Welcome to the Essentials of Radiology Pediatric session. This is going to be MSE S33. I have no financial disclosures. So I'm from Seattle Children's Hospital out in Seattle, part of the University of Washington, and today I'll be talking to you about pediatric airway emergencies. Bread and butter pediatric radiology. Again, nothing to disclose. And we're going to start with this image demonstrating that oh so uncomfortable air hunger, distension of the oropharynx, distension of the hypopharynx. And we won't jump to the diagnosis at this point, but just as a reminder, as we discuss pediatric airway emergencies, hopefully giving you some tools so that your diagnosis will be swift and accurate. Our outline is going to include stridor, airway foreign bodies, and asthma. Stridor is that high-pitched crowing when you have a obstruction of the upper airway above or at or above the level of the thoracic inlet. And with stridor, almost inevitably, it's going to come with two views of the neck. To quickly take you through how I evaluate stridor, I first begin my evaluation looking at the soft tissues of the neck. Is there asymmetry? Is there tracheal deviation? I move on to the subglottic region, and with stridor, there is that buzzword of looking for a steeple sign. Here in a normal soft tissue of the neck, there is no steeple sign. That is that concentric narrowing in the subglottic region. One thing I have a very difficult time is often saying, is that a steeple, is that a cupola? And I get lost somewhere in those definitions. And so I'd like you to move your eyes over to the lateral view and focus on the lateral subglottic region, because that can really confirm subglottic edema. I then move on to the rectopharyngeal or prevertebral soft tissues, looking for abnormal thickening. What is abnormal thickening? Well, thickening in a pediatric young child, it would be soft tissues that are thicker than the AP diameter of the adjacent cervical vertebral bodies at C2 through C4. In older children, we use 6 millimeters in 10 years and older. I then move my search pattern to the epiglottis. I want that to be thin and distinct. And whenever I look at the epiglottis, I'm going to look at the area epiglottic folds. Here, it is an arrow pointing to nothing, because in a normal individual, you cannot see those area epiglottic folds. So we have our search pattern down, and our search pattern will then bring us again to those soft tissues of the neck, which are symmetric. But when I go to that subglottic region, well, this does look like we have concentric narrowing, and sure enough, it looks like a steeple. But like I said, to confirm, let's look at the lateral. And if we go back for a second, if you look at that lateral, I dare you to follow that tracheal airway or the upper tracheal airway all the way through its path. And you can't, because there's effacement, and that's what you see in that subglottic edema. So this is a classic example of viral croup, also known as laryngotracheal bronchitis. The peak age is 6 months to 3 years. The etiology is most often parainfluenza, but other both viruses and atypical bacteria can cause it. And then the role of imaging. Why did they get these radiographs? Is it because they needed to see the staple sign? Not necessarily. It's actually because they wanted to make sure that on that list of the differential, there wasn't another cause where they needed to change their care. So that makes the differential of stridor an important differential to know. Infection is the major category. We just talked about croup, but in that list is epiglottitis, retropharyngeal abscess, and acute bacterial tracheitis. Hemangioma, or specifically subglottic hemangioma, is in the differential for stridor, especially in the infant age, and foreign body. And foreign body is not only in the upper trachea, but in the adjacent upper esophagus. So using that differential and then using the tools that we have for our search pattern, as you look at this single lateral view, it's hard not to draw your eyes toward that thumb-like epiglottis. But like I said earlier, if we're going to look at the epiglottis, then we should look at the area epiglottic folds. And here, unlike that normal radiograph, there's no question where those area epiglottic folds are. So this is epiglottitis. This is an old radiograph at the time where Haemophilus influenza type B vaccine did not exist. the corresponding view being the autopsy showing that swollen epiglottis. Which brings us to defining acute epiglottitis. So the etiology and epidemiology have changed over time. In the pre-vaccine era, we would have 3-year-olds who were infected by Haemophilus influenzae type B. We now vaccinate, so the average age is around 14 years, and bacteria such as staph, strep, and pertussis are the causes of epiglottitis. The imaging clues to hammer it home, we look for an enlarged epiglottis as well as enlarged area epiglottic folds. And this is an airway at risk, and the next thing you see after you see that radiograph should be you grabbing the phone to call someone who can manage that airway. Not all thickened epiglottises are abnormal. This is omega epiglottis if you look at that thickened epiglottis, but then no thickening of the area epiglottic folds. And omega epiglottis can be associated with laryngotracheal malacia, where the epiglottis is shaped like an omega and thus giving you a thickened view on the lateral view. Still with stridor, 6-year-old, stridor and fever. I go through my search pattern, do not see any definite subglottic edema. The prevertebral soft tissues look okay, the epiglottis looks okay. But then I go back to that trachea, and although they are subtle, those are real findings. These are thin membranous findings within the trachea. And this is an example of bacterial tracheitis. Bacterial tracheitis, when I've looked at it in the textbooks, it sure looks angrier than the appearance that I showed you today. But in my experience, these subtle findings are what I've come across for bacterial tracheitis. Epidemiology is different than croup, which was 1 to 3. In bacterial tracheitis, the typical age is 6 to 10 years. We look for these thin septations or membranes. This is also an airway emergency, and endoscopy is used for definitive diagnosis. Perseverating on stridor, here's a 9-year-old with fever. Here, the lateral soft tissues clearly are asymmetric. And when I go to the lateral view, I look at the prevertebral soft tissues, and when I compare that AP diameter, there's no question that the prevertebral soft tissues are clearly larger. Also note that you have somewhat bowing of the anterior margin of the prevertebral soft tissues, and that cervical lordosis has turned to cervical kyphosis, all demanding that we do additional imaging, and additional imaging should be a CT scan. On the CT scan, we see an abnormal fluid collection. Not only is it a fluid collection, but it is rim enhancing. It has irregular margins. On the lateral view, note that it does not taper superiorly and inferiorly, but is somewhat rounded. This is a retropharyngeal abscess. When we look at that CT scan, the differential that we should think about would be possibly a suppurative node, which would be more rounded, normally does not crisp midline, retropharyngeal edema, which we'll look at shortly, and in young children, lymphatic malformations. We also look for complications. You can have vascular complications, which include thrombus, pseudoaneurysm, and narrowing. You can have embolic complications, including both emboli to the brain if it's arterial, or emboli to the lungs if it is venous. And then with a retropharyngeal abscess, you're concerned about the danger zone, and this tracking of the infection back down into the mediastinum, or down into the mediastinum because of mediastinitis. So our reporting responsibilities are going to include the extent of inflammation, complications that we see associated with this infection. And then the question is going to be, as that ear, nose, and throat doctor's hanging over your shoulder because they have already sedated the child to get to the CT scan, is this something we can drain? And you really want to get that right, because let's not say I have the experience of getting it wrong, but I've heard that those ear, nose, and throat doctors don't like going in and draining something that's not drainable. Speaking of which, we have 2 views from a contrast-enhanced CT scan, which shows fluid density in the retropharyngeal space. But notice the difference from what we saw on the true retropharyngeal abscess. There's no rim enhancement. And if we look on the lateral view, the superior and inferior edges somewhat taper. And this is retropharyngeal edema. There's a nice paper by Hoang et al. From AGR back in 2011 describing, is it an abscess? And this is just edema. You do not want to drain this. One other thing with evaluating that prevertebral soft tissues If it looks abnormal and you can't explain why it looks abnormal, don't be convinced to get the CT scan as your next step. So here, I can't quite define the prevertebral soft tissues. I'm not sure where they start. I'm not sure where they begin. In fact, I have no idea what's happening in that hypopharynx. And I try to explain why that might be. And one thing that catches my attention is the hyoid bone, which normally sits a little bit lower, is right below the level of the mandible. So instead of getting a CT scan to explain what's happening, consider repeating that radiograph. Here, same individual, 5 minutes later, the patient's not swallowing during the time that you take the radiograph, and this is a normal soft tissue of the neck. So before you get the CT scan, think about, is this an artifact? Is it positioning artifact? Is it a swallow artifact? And if so, repeat the radiograph. Image gently. Here's a 7-month-old with persistent stridor. I'm now perseverating on stridor at this point. 2 views, distended hypopharynx. Maybe there's some narrowing on the AP view of the subglottic region. On the lateral view, this is a typical radiograph of a non-cooperative patient who's decided to raise their shoulders exactly in the area you'd like to look. But I beg you to look a little bit closer and try to follow that upper airway. And when we do, it comes down to a point. So the fact that it's persistent stridor, in those cases where croup would not be the diagnosis that the emergency physician is thinking, that is almost reason enough to get a CT scan or certainly additional imaging. And what we see on that CT scan is a avidly enhancing soft tissue mass. So in that differential for stridor is subglottic hemangioma. This is a subglottic hemangioma. One game that you don't want to play as a radiologist or as a physician in general is where is the airway. I see jugular, carotid jugular, and in the middle, I see that subglottic hemangioma where the airway should be. This child actually did well. The epidemiology for subglottic hemangioma is infants less than 6 months. There can be associations with cutaneous hemangiomas, and it can be associated with facies, which is a neurocutaneous syndrome. Just not to go through each one of those letters, but H would be hemangioma. Treatment options include steroids and propranolol, which has been shown to cause quicker involution of these hemangiomas. And if medical treatment fails, surgical treatment is a possibility. 1-year-old with stridor. So the cause of the stridor here is not difficult. We see it both on the AP view and we see it on the lateral view. But besides just describing foreign body, we're better than that. And we notice that as we zoom up on our lateral view, we look at that AP view and we see this peripheral radiolucency. In addition, on the lateral view, we see a beveled edge. So not only is this a foreign body that needs to come out, this is a button battery, which within 2 hours will start causing necrosis. And the question then may be, can you be even more useful? Where is that necrosis going to occur looking at these 2 radiographs? And it turns out we can help them with that. That is the negative pole, which is the narrow aspect of the button battery, which causes the necrosis. So if you were going to go in endoscopically or if you were going to do a barium swallow in this patient, I'd be concerned about necrosis on the anterior aspect of the esophagus. That radiolucency, just on the AP view, again, important to find necrosis is occurring within 2 hours. This is what, when I say a button battery, this is what I'm talking about. It is these, in most cases, 20-millimeter button batteries that are getting stuck in the esophagus. It was taken out of their toy or wherever they may have found it. So with button battery ingestions, 3 ends, negative, narrow, necrotic. It's the negative pole or the narrow side which causes the necrosis. Size matters. It's mostly the 20-millimeter lithium batteries that are getting stuck, not the smaller batteries that get stuck in the esophagus. And then the imaging protocol. You're going to image the esophagus, you're going to image the abdomen, but don't forget to image the neck, and that you don't want one stuck in the nasopharynx. And then finally, it is worth your while to spend a moment on www.poison.org/battery. They have a spectacular flowchart of what to do. And we're not going to go through each and every step, but know that it'll categorize it by age, by size, by type of battery, whether or not they ingested a magnet, and give you what the imaging protocol should be. It really is worth your while to read. So we looked at a button battery. Here is the corresponding foreign body that looks a lot like button battery, but is just a standard coin. The issues with coins is you don't know how long they have been there, and could have caused a fair amount of inflammation just because they've been there for a long period of time. So here, there's no bevel, there's no peripheral radiolucency. This is a coin. We now will test our skills here for extra credit, coin or button battery. Exactly, it's a coin, and then those who are particularly good have not fallen for the satisfaction of search and are looking elsewhere in the radiograph and are concerned about those calcifications in the right upper quadrant. And yes, that is a large neuroblastoma that is hanging out underneath the diaphragm. The funny thing is that the neuroblastoma was known about. This was just a radiograph before they started chemotherapy that happened to identify the coin which had been there for a long time. So we just discussed the differential of stridor. We talked about infection, we talked about hemangioma, we talked about foreign body. We're moving on to airway foreign bodies. Airway foreign body. Here a patient presents with a sudden onset of wheezing and tachypnea in a 20-month-old. Before we try to diagnose which side we think that foreign body is, let's just briefly talk about what our options are. Is this single radiograph enough, or do we want to do additional imaging to help us localize which side it is? At our institution, for a long time, we did decubitus chest radiographs, meaning we did a right side down, then we did a left side down, thinking that with the right side down, you're forcing expiration out of the right side. With the left side down, you're forcing expiration out of the right side down, right side, left side down, left side. And the hope was that would then localize where the foreign body may be. What we found actually in doing our retrospective analysis is that it did a good job of increasing our false positives. It did not do a good job of increasing our true positives. Other alternatives include inspiration, expiration. For those of you who have 1 to 3 year olds, the peak age for foreign bodies, you can imagine how helpful they are when you ask them to breathe in or breathe out. But you can do forced expiration. Your technologist may or may not like you doing that. We found that the forced expiration views did not demonstrate great accuracy. Fluoroscopy is another option. We use that as a overall problem solver tool when necessary, but maybe not as a standard at our institution. And then bronchoscopy is that final step to look for the foreign body. So in our research, it would suggest that you have to think long and hard whether or not the time and the radiation is worth doing additional images to localize. Often with a single radiograph alone, you'll have a good guess of where that foreign body is, and that can be enough to help direct the bronchoscopy. So same case, looking at this as a single radiograph, I'd say, gosh, there is some opacification in that right middle lobe, right medial base. Maybe that right lung is hyperinflated. We did this study prior to a change in our policy where we did do a right lateral decubitus, which showed no decompression of that right lung, and the left lateral decubitus showed still a hyperinflated right lung. So the foreign body was on the right side. So with airway foreign bodies, that age is 9 months to 13 years. The grasping reflex matures so much more faster than the frontal lobes to say what it is that what should go in the mouth and what should not go in the mouth. The peak is 1 to 3 years. The site is the right mainstem, more frequent than the left mainstem, and vegetables, non-radiopaque vegetables being the most frequent. Now, I was told when I was in medical school that 50% of what I learned was no longer going to be true, but I did learn that peanuts go down the right mainstem bronchus, and I look at these numbers and it seems still to be true. Moving on. Asthma. So with asthma, as a radiographic emergency, I would say no, actually you deal with that in the emergency room and there are no radiographic findings would have been my initial reaction. My experience has been different than that. So here we have a 16-year-old who has shortness of breath and neck crepitus. Looking at the lungs, I'd say those are clear lungs. Because I say it frequently, there's probably some peribronchial thickening and some the lung volumes on the higher end of normal. So this would be suggestive of reactive airway disease. But before I move away from that radiograph, my eye catches the superior aspect of the radiograph, which demonstrates more definition of the neck musculature than I would like to see. I'll zoom that up for a second. So we have subcutaneous emphysema, which is interdigitating between the soft tissues of the neck and the supraclavicular region. If you don't believe me, we'll get a CT scan, which demonstrates that same subcutaneous emphysema within the neck. But what I think is remarkable, and I find this somewhat frustrating, is the degree of pneumomediastinum that you see on the CT scan that is so hard to see on the radiograph. And what is occurring here in a patient with asthma is during their asthma exacerbation, they rupture an alveolar sac in the periphery. That air is tracking backward along the bronchovascular bundle, is then tracking into the mediastinum, then tracking up and into the soft tissues of the neck. This is called the Macklin effect. One thing that I find is for those ER physicians who have worked in trauma centers, they see the subcutaneous emphysema within the neck, and their gut reaction is that we need a barium swallow because clearly there could be an esophageal injury. And certainly there are some cases where that is true, but in a patient who comes in with an asthma exacerbation, the more likely entity here is going to be an alveolar sac rupture and then the pneumomediastinum and subcutaneous emphysema tracked by that, which is somewhat self-limiting. The issue is that if they have bad enough subcutaneous emphysema that they need to, or bad enough of an asthma exacerbation that they need to be intubated, we're then adding positive pressure to this, and they can get fairly significant subcutaneous emphysema. Axial view showing the same thing. So a 10-year-old asthmatic with cough and shortness of breath. The question here is an additional study necessary? The ER physician would say, well, you've got opacification in that right base, and I can't see the right costophrenic angle. So my concern is in this child who is presenting with cough that this is pneumonia with empyema. And on some level that could be true, and with that dense of opacification I can't tell you exactly what's going on in that right lung base. But I would point out that there is this cutoff sign within the right main bronchus. And in an asthmatic who has a tendency to form mucus plugs, this is more likely going to be mucus plugging. In addition, when I look at the mediastinum, it's shifted over to the side of opacification, so I certainly don't think that we have an empyema that's pushing things away. I sometimes win those battles and I sometimes lose those battles when I talk to the ER physicians. Clearly I lost that battle as we did do additional imaging, which shows that there is a mucus plug in the right main stem bronchus with associated atelectasis. So with asthma, the imaging findings that you are most often going to detect, we'll talk about hyperinflation and parabronchial thickening of reactive airway disease. The ones that I want you to at least have in the back of your mind as a patient who with asthma presents with an abnormal radiograph are the complications of mucus plugging, the consolidation atelectasis that you can get from that, and the pneumomediastinum that you can get from an alveolar sac rupture. Going back over what we have looked at today. Starting again with that lateral view that we saw earlier, that air hunger, that radiographic demand that we make a quick and accurate diagnosis. The distension of the hypopharynx here, focusing only on the lateral view, but clearly if you follow the upper airway, we lose definition of that upper airway. This is subglottic edema, and with Strider 9 times out of 10, it's going to be secondary to croup. But we're better than knowing 9 times out of 10. We'd like to know what that 1/10 could be, so when it crosses our reading space, we're ready for it. So what we've learned the differential diagnosis of Strider. Again, we think about infection. Outside of croup, we think about epiglottitis. We think about retropharyngeal abscesses. We think about hemangiomas, and we think about foreign bodies. The 3 ends of button batteries. The button battery that you now recognize because you see that radiolucency within the periphery. The button battery that you now recognize because you see the beveled edge. The button battery that you're now useful to the clinician because you can tell them where the necrosis is, which is going to be on the narrow side, which is the negative pole. And finally, asthma complications. Your gut reaction when you see the history of asthma is that this is going to be a fairly normal radiograph. You're going to look harder. You're going to make sure that you do not miss subtle pneumomediastinum or subtle subcutaneous emphysema if those two things are possible. I thank you so much for your time. Have a good day.
Good afternoon. Again, this is course MSc S33, and I am Diego Jaramillo from the Children's Hospital of Philadelphia, and I am going to be talking about imaging of osteomyelitis in children. And the three learning objectives from the handout are to review epidemiological changes with imaging implications, to talk about imaging findings in pediatric osteomyelitis and its complications, and to talk about contribution of the different imaging modalities and imaging algorithms. So, osteomyelitis in children is a disease that is difficult clinically because it occurs in very young patients. Mean age is 7 years, and more than half are younger than 5 years of age. And only 30 to 75% have positive blood cultures. And imaging is very important because we have to aid and to guide the clinicians in two things. First, the culture of bone or soft tissue has a higher yield, so it is important to pinpoint the focus of infection. And secondly, increasingly there are abscesses as part of the presentation, and part of the therapy, in addition to antibiotics, is going to be the surgical debridement and drainage of abscesses, which again requires image guidance. The epidemiology of this disease has changed significantly, and it is important to know what has changed. And in the United States, there has been a 2.8-fold increase in the incidence of community-acquired Staphylococcal aureus infections. And actually now, methicillin-resistant Staph aureus causes 30% of the infections, and this percentage is growing. Also, there is increased virulence of community-acquired Staph aureus, regardless of whether it is methicillin sensitive or methicillin resistant. And the reason is that there is a gene called the gene encoding Panton-Valentine leukocidin, or PVL, which results in multifocality of infections and also in a higher incidence of subperiosteal collections, myositis, and pyomyositis. And actually, deep venous thromboses now are present in 10% of cases of osteomyelitis. So in the past, we never used to look for these soft tissue findings and for the vascular findings. Now it has become imperative because they are very frequent. This is a case in point of a patient with methicillin-resistant Staph aureus who presented with pain in the wrist. The plain radiographs only show deep soft tissue edema, but of course the T1 weighted image shows abnormality in the distal radial marrow, and there is enhancement of the subperiosteal tissues consistent with subperiosteal disease. But unsuspectedly, when this patient also presented with some findings around the hip, and the hip was actually imaged, we saw that there was extensive purulent collection that went from the region of the inguinal region and went into the pelvis, displacing the bladder and also having subperiosteal infection. This is another patient, a 5-year-old, who presented with poorly defined symptoms in the chest and in the lower extremity. So in the chest, we see some infiltrates in the lower base, and when we started imaging the lower extremity, we see high signal intensity in the femoral vein, and deep down in the leg, we see that there is infection in the proximal tibial metaphysis with an adjacent abscess. So this patient had osteomyelitis with an adjacent abscess, with a deep venous thrombosis, with a pulmonary embolism. And you can see here the extensive deep venous thrombosis, which is non-enhancing, and the areas of pulmonary embolism. So again, these type of findings are things that are becoming increasingly frequent and which we didn't used to suspect in the past. On the other side of the spectrum, on the benign side of the spectrum, it turns out that in Europe and in the Middle East, there have been reports of this organism called Kingella kingae. Kingella kingae now seems to be the most prevalent organism in osteomyelitis when you do PCR analysis. It is a disease of very young patients, so most of them are under 4 years of age, and it has a milder clinical course than the staphylococcal infections, and primarily it has epiphyseal involvement, so it produces more chondritis rather than osteomyelitis, and fortunately it is responsive to antibiotics. I'm going to show you an example of the type of disease that you see with Kingella, and this is also to bring up an important point of imaging. A T1 weighted imaging in an infant, dark marrow, which is normal, dark epiphyseal cartilage, which is normal. The stir image doesn't show much except for extensive edema in the soft tissues, but after we add gadolinium, we can see that there is absence of enhancement in the anterior aspect of the epiphysis with extension of the disease into the soft tissues. So two things are important here. First, epiphyseal cartilage infection is something that you only see with gadolinium enhancement, and this has been reported relatively recently. And secondly, Kingella kingae infection is the disease that typically produces cartilaginous infections in the young. In general, with osteomyelitis, we're going to have few localizing signs, but it is important to remember that your suspicion should always be in the lower extremities because that is where the growth is occurring and where the vascularity is the most abundant. And 1/3 of them, for that reason, affect the knee. 1/3 of the patients also have a history of recent trauma, and that is not a serendipitous finding. It is actually, it seems that trauma causes tissue disruption, which in turn predisposes implantation of bacteria in this region. And increasingly, because of the PVL gene, we are seeing multiple foci of disease. This is an example of the association with trauma and osteomyelitis. This is a patient who had child abuse, had separation, as you can see on this unenhanced T1 weighted image, a separation between the cartilaginous epiphysis and the rest of the metaphysis, typical finding of child abuse. And after gadolinium enhancement, an extensive soft tissue abscess is seen adjacent to the bones of the knee, and you can see here that the abscess originated from the bone into the subperiosteal region and then into the soft tissues. So important to remember, trauma predisposes to infection. The initial focus typically is in the metaphysis because the metaphysis is where you have the most abundant vascularity, and this is hematogenous disease. In the metaphysis, you're going to find sluggish flow in the metaphyseal sinusoids, and you are also going to find decreased phagocytosis. Typical example of a mild osteomyelitis where you just see some abnormality in the marrow and in the subperiosteal tissues. It's important to remember that sometimes it is difficult to distinguish between the early focus of infection and the normal changes that occur because of hematopoietic marrow in the metaphysis, both of which produce low T1, high T2, and stir findings. But it is important to remember that in the hematopoietic marrow, there is more fat than in infected marrow. Typically, hematopoietic marrow has 40% fat, and therefore hematopoietic marrow is going to be brighter than the adjacent muscle, whereas infected marrow will be darker or isointense to adjacent muscle. Metaphyseal equivalents occur at the chondroosseous junctions in flat bone. So if you're dealing with the pelvis, where is the metaphysis? Well, the metaphysis is going to be adjacent to the triradiate cartilage, for example, and in this case, you're going to have a little subtle focus of infection adjacent to the triradiate cartilage. Important to remember that in the pelvis, foci of infection are subtle, but they are associated with big soft tissue abscesses or big soft tissue areas of edema. Now, in the round bones, of course, it's hard to find metaphyses as well. And the metaphyseal equivalents are going to be in the periphery of the bones. And here you have an area of infection at the junction between the main bone of the calcaneus and the calcaneal apophysis. From the initial focus of the bone, in the metaphysis of the bone, the infection can proceed into the rest of the bone, into the subperiosteal tissues, and notice in this diagram that the periosteum inserts very tightly in the perichondral junction, and so therefore typically a subperiosteal abscess it can elevate the periosteum, but it stops suddenly at the perichondrium. And then it can also go into the soft tissues and of course into the joint, and finally into the epiphysis. So how does an intraosseous abscess look by imaging? You're going to have a non-enhancing center, an enhancing rim, and it is important to remember that where the gadolinium does not go, the antibiotics will not go either. And therefore, if you have a large non-enhancing area, you are going to require drainage. Subperiosteal abscesses should be suspected if there is no response to antibiotics after 48 hours, and typically they are non-enhancing. They are bound by hypointense periosteum, and you can see here the periosteum surrounding the bone like a cuff with subperiosteal disease. And like I mentioned earlier, here you have the elevated periosteum adjacent to the focus of osteomyelitis, and then it stops at the perichondrium because this perichondral junction is very tight. Also important to remember is that you are going to see fat globules in the older patients, and these fat globules are important because they are pathognomonic of osteomyelitis, and they result from the lysis of marrow fat and then from the escape of that fat into the subperiosteal tissues that are affected. But like I said, it's something that is seen primarily in puberty and adolescence, not in the younger patients. It is also important to remember that subperiosteal abscesses are now multifocal, as we can see in this case that has osteomyelitis of the distal femur and proximal tibia and subperiosteal abscesses in both regions. Epiphyseal extension is more common in infants because until 18 months of age, there are free vascular communications between the metaphysis and the epiphysis. And later, the physis is going to act as a partial barrier, but only as a very partial barrier beyond infancy. And typically, a focus of osteomyelitis in the metaphysis can destroy the physis very easily. So here we have a focus of metaphyseal infection going through the growth plate and then going into the epiphyseal cartilage and producing chondritis. The disease can also extend into the soft tissues. Notice the area that is very, very large. In this case, it is not stopping into the perichondrium. Now, this is another case where you can see abnormal marrow in the distal tibia on T1 and on STIR images. But notice that you can see things very clearly on the post-gadolinium images, and on the axial you can actually see that there is a draining sinus. When we looked at the value of gadolinium, except for the patients that have chondritis in the period of infancy, but if you look at the value of gadolinium in the older patients, you see that gadolinium does not increase your sensitivity or specificity, but it does increase the reader confidence, particularly when you are dealing with the decision as to whether you have an abscess or not. So in a child with suspected osteomyelitis, you begin with radiography, not so much to look at the findings because they tend to be very late, but mostly because you want to exclude other pathology. This patient had symptoms related to the ankle, and notice that in the periphery of the talus, where you expect the metaphyseal equivalent to be, you have a little bit of destruction, which is more evident on the follow-up radiograph. Sonography is actually pretty useful in diagnosing the subperiosteal and soft tissue findings, but and in this case you have the fibula. This is the fibular shaft. This is the fibular periosteum, and this is the subperiosteal abscess, which comes, which stops at the perichondrium. And notice that it's probably even more evident on ultrasound than on MRI. The limitation of ultrasound, of course, is it does not let you see what is happening within the bones. Notice that I have not talked much about scintigraphy, and although scintigraphy has typically been the main diagnostic modality for osteomyelitis, I would contend that because of the prevalence of soft tissue abscesses and the importance of the detection of these soft tissue abscesses in therapy, modalities that can image the soft tissues are going to be much more useful than scintigraphy itself. MR imaging is perhaps the most important modality if you have it available, and typically we do water-sensitive imaging in two planes, a gadolinium fat-sat T1 imaging in axial and one of the longitudinal planes, and increasingly we're doing more whole-body stir as the presence of multifocal infections has become more prevalent. And or at the very least, we do imaging stir of both lower extremities. There is a recent study questioning the value of bilateral imaging, saying that there was no change in management. And I would say that this has not been my experience, although this is a group that produces excellent work, and I respect their findings a lot. But this has not been my experience. I'm going to show you a case, for example. This is a patient that had proximal tibial osteomyelitis. On the left, we can see actually that there was tibial osteomyelitis on the right, but also there is osteomyelitis on the vertebral body. And I think that knowing that there is vertebral osteomyelitis in association with tibial osteomyelitis is very important. This is another case of a younger patient, an infant with symptoms related to the left hip, and there are findings related to osteomyelitis of the left hip. But notice that there was also an effusion in the left shoulder. And when we looked at the shoulder with higher resolution imaging, we see that there is an unsuspected necrotic lesion there. And this is actually what was more important from the standpoint of management. So I do think that more and more we are forced to do a very quick scan through the entire body, at least with stir coronal images. Now, in terms of complications, one of the most important complications is physeal injury from osteomyelitis, because typically a focus of metaphyseal osteomyelitis is going to extend into the physis and produce growth arrest. Epiphyseal osteomyelitis is more chronic and seems to be less damaging. The final complication is growth arrest, and you can see in this case the normal physis and contrasted with the closed physis adjacent to the focus of osteomyelitis. In this patient, we also, in a younger patient, we have what looks almost like a skeletal dysplasia. This almost looks like achondroplasia with bony bridging in the central aspect of the physis. When we do the T1 weighted images, we see that actually there is asymmetrical discontinuity of both the distal femoral and the proximal tibial physis. And this was a sequela of osteomyelitis, a 5-month-old girl with prior neonatal sepsis. So infection can definitely affect the physis and be very disabling in children. Another complication is chronic osteomyelitis, and I would say that sequestra are better seen with CT than with MR, if that is what you suspect. But draining sinuses are very well seen with MR, and in general, increased T2 signal or enhancement is a sign of activity in chronic osteomyelitis. I must say that this is an area where PET CT or PET MRI can be very useful if you're thinking about chronic osteomyelitis and you cannot tell by other imaging modalities whether it's present or not. PET imaging can be extremely useful. This is a case of chronic osteomyelitis, again showing persistent activity in the bone marrow, thickening of the cortex, and evidence of abnormality both on T2 and on post-gadolinium images within the cortex, both of which indicate active disease. Chronic osteomyelitis can also present with a Brodie's abscess, and Brodie's abscess has the same configuration on all modalities. There is always a center that is necrotic, a well-defined inner rim, and a fading halo, which can be of sclerosis if you're dealing with CT or radiographs, but it can also be marrow edema if you're dealing with MRI. Another complication is the development of cloaca. Cloaca comes from the Latin sewer, and it is going to be the area where the infection drains. Here you have a focus of distal metaphyseal osteomyelitis with an abscess. Notice that there is here the cloaca or the draining sinus, and you can see that it is going into the soft tissues and defining a soft tissue abscess. So, to summarize, osteomyelitis has become a much more serious disease in children. Why? Because it is more aggressive, it is more frequently multifocal, and it is affecting more frequently the soft tissues, producing subperiosteal abscesses and deep venous thromboses. The methicillin-resistant Staph aureus has markedly increased in frequency, and this is very serious. And the PVL gene, which affects not only, which is present not only in methicillin-resistant but in methicillin-sensitive Staph aureus acquired in the community, accounts for multifocality, subperiosteal abscesses, deep venous thrombosis, and a high CRP on the blood tests. Kingella-Kingay infections have become increasingly frequent and may be the most frequent organism in children under 4 years of age, and they typically produce epiphyseal cartilage osteomyelitis in a much more benign clinical course. Trauma predisposes to infection in about 1/3 of the cases. If pregadolinium is negative, then you do not need gadolinium because gadolinium enhancement of nothing is nothing. So you do not need post-gadolinium in those cases. But the exception is epiphyseal cartilage infections in the very young, because infectious chondritis can only be seen with gadolinium enhancement in some of the cases. And finally, multifocality is forcing us to do more and more whole body MRI. Thank you very much.
Thank you very much. Could I ask everybody that's sitting around the outside to come and sit down and be comfortable, please? Thank you. My name is Dr. Catherine Owens. I'm a paediatric radiologist from London in the United Kingdom. I'm very pleased to be in Chicago. I'm very honoured to be amongst such superb speakers. And I'm going to talk to you about a cardiac disease in children. The title of my talk is Cardiac CT in Children Beyond the Coronary Arteries. In most adults, the reason you're doing CT is to look at the coronaries. And in children, they're usually less of a problem. So I'm going to tell you why, how, and when I would use cardiac CT in children. So why would you use it? Well, there have been very good guidelines which have been released. Very good paper from the European Heart Journal in 2003 was chaired really by the consultant who is the head of department in cardiology. And as he was the head of the department, he came to us and said, look, we need to work together as a team to integrate cardiac imaging, because we've written these guidelines, there's a very clear role for grown-up congenital heart disease or congenital heart disease to be monitored with cross-sectional imaging. So we were rather late in the game at Great Ormond Street. We started our joint venture in cardiac imaging in 2003. And prior to that, a patient would have an echocardiogram, and if the echocardiogram was satisfactory, made the diagnosis, they would proceed to operation or conservative treatment. If there was more complex anatomy, they would proceed to a diagnostic catheter, which is, as you know, a very invasive tool in children, involves femoral arterial or venous puncture and manipulating catheters through small vessels, and not very pleasant. And then the patient would go on to have further management. So we introduced another step, and the step was cardiac MR or CT, having done the echo, to decide whether or not this patient needed any further interventional management. Some patients will still go on to have catheterization, but usually that catheterization is for not for diagnostic purposes but for therapeutic purposes. So they will try and treat lesions with interventional cardiological procedures. So it's good for the patient. The most important thing to remember, the addition of this step makes it safer and more palatable for the patient, and that's really what we've got to focus on. So this must be an integrated approach. I think it's very important for me to put cardiac CT into context. There is no competition between cardiac CT and cardiac MR. They are very, very synergistic. They sometimes are both needed, but they both have strengths and weaknesses. And it's also important to make you think that those decisions must be discussed in a multidisciplinary team meeting, and then decisions as to which test to go ahead and do, or whether indeed you need both. And just focusing on CT, CT is superb when you need combined anatomy of both the heart and the lungs. And increasingly, if you do cardiac CT, you will see very interesting combinations of heart and lung pathology. And that's why it's absolutely vital that radiologists do contribute to the reporting of these images, because there is a high association of lung abnormalities with congenital heart disease, and we really are experts. Unfortunately, whether you love or hate cardiologists, they do tend to forget that there's something beyond the pulmonary arteries. Everything beyond the pulmonary arteries is not interesting. So your job as a radiologist is to make sure that they're taken seriously, the lungs are actually taken seriously, because they are important. Clearly, cardiac CT comes with a radiation burden and a very exciting launch of new machines here, a very dramatic increase in the technological advantages of CT with dose reduction and better quality imaging. Images that are fit for diagnostic purpose, that is, diagnostic, but at the lowest dose that you can achieve with good diagnostic imaging. One of the very attractive things, in my unit, we do a lot more cardiac MR than we do cardiac CT, and we always give general anaesthesia to children under 5, but sometimes under 8. And that is a significant morbidity factor, I think. The time of the scan and the resources, many people just don't have the ability to get the access to these scans. Whereas with CT, it's much quicker, and in fact the newer scanners are really very, very quick. We always have to remember radiation exposure, and computer tomography has been blamed and shamed, and we have to really remember that we are having a risk-benefit ratio. For every patient that has a CT, you've got to think about how will this help the patient, what are the benefits to the patient in terms of risk-benefit ratio. So you never isolate risk, you always think about benefit. The dual source CTs, the very fast machines that we have these days, are superb, and from our perspective this is what really helped us to work with children, because the heart rate in children, as you know, is often between 100 and 200 beats per minute, and we never beta block children. We always try to do the scan with gated scans, and the temporal resolution of the newer scanners are superb. I think there's a new scanner, the most recent machine with dual source had a 75 millisecond temporal resolution, but this is even improving as we speak with the launch of newer scanners. And what does that mean? Well, it means that you can acquire very crisp images even with a fast heart rate. And this machine we have is the prototype machine, a dual source scan, which has an 83 millisecond temporal resolution and provides excellent pictures. So how do we scan? Well, we have to optimize the radiation dose, but we have to get images which are diagnostic. There's no point in doing images which are so low dose, so noisy, you don't get the information. Very important to think about that. Fit for purpose. And the benefits of the test must outweigh the risk of the test. This is in my department. We carefully monitor weight-based effective doses measured with a CT Expo Child Phantom. And if you look, it's a rather busy slide, but if you look at the way that you can acquire chest imaging and cardiac imaging, if you look at a traditional multi-slice scan of the chest in a child under 7 kilograms, all the parameters are given here, you'll see the effective dose in millisieverts, depending whether you're male or female, is about 0.8 millisieverts. If you do a spiral angiography, if you do slightly smaller pitch, tighter pitch, slightly higher, again, under a millisievert. Retrospective gating is significantly higher in dose, and if you look, about 2.5 times the effective dose for a retrospectively gated scan. I'll show you what the benefits are and when maybe you will want those benefits. But really a win-win situation, I think, is prospectively gated scans, which give you very good pictures with cardiac gating for about the same effective dose as a normal spiral scan. And we increasingly use prospective gating. And I'll show you the difference between the image quality in a moment. Contrast dosing in children, very easy. All you do is you multiply the patient's weight by the dose of contrast you want, usually between 1.5 to 2 mils per kilogram. And we usually use a non-ionic contrast with an iodine concentration of about 300. Contrast injection and injection rates are very important, and we're very fond of power injectors. We're fond of them because we think they're quite safe, because they do not allow you to go above a specific pressure. And if the pressure rises, there's a specific measurement of pounds per square inch, the pump will stop. And we'll show you in a moment some of the data from Sue Cast. She's looked at the data back in the 90s and shown that power injectors are just as safe as hand injection, and we've had the same very similar data from our group. So the flow rates, we would normally set the flow rate at about 1.5 to 2 mils per second. If you have a very peripheral catheter that is tenuous, or a scalp vein catheter in a child who's tiny, really you shouldn't use pump injection. You should use very slow hand injection, and that's not ideal for cardiac CT. Back in 1995, Sue Cast published in Pediatric Radiology extravasation at injection site rates for power injector versus manual injection, and they were very similar, and that work has been replicated in our centre and several others. So I think you can say that the practice is safe. One of the most difficult things to decide upon is the scan initiation time. So when you start the contrast injection, when do you start the scan? And how do you do that? We have several choices. You can do a fixed time delay depending on the age and the weight of the patient, and we usually do that for conventional thoracic studies, so we just have an empirical delay and we'll start scanning at an empirical time depending on the child's heart rate and weight. There are various different types of computer-assisted triggering for angiographic studies, and I'll show those to you now. So in our department, we'd actually start scanning about 30 seconds after the injection has started via a pump at a relatively fast rate. However, in tiny children, and in children who are complex and difficult and have abnormal anatomy, really you should be in the scanner, not in the scanner itself, but outside in the console room with the techs and looking at the images and acquiring the images at a time when you know you have contrast in the structures you need to see. And how do you do that? Well, if you have an adult, you can put your region of interest, you can find the level that you're going to do your surveillance, your low-dose surveillance scan. You can put a region of interest in the mediastinum and on the vessel that you want to look at, and then you can start scanning when the region of interest, Hounsfield unit, meet between 80 and 100, and then you trigger your scan and you start scanning. I would say to you that's very difficult in a child, because I think if you're trying to work out where the aorta or where the pulmonary arteries are, really very hard. So I find that rather difficult in small children. So what we do is manually bolus track. We do low-dose surveillance scans at the region that we want to see the contrast, and we'll do low-dose scans, and then we'll continue with the contrast, and we'll put the region of interest outside of the patient, and we'll monitor at a specific level. As soon as we see contrast where we want to see it, we'll start the scan. So I really think this is the only way to do it properly and not to make a mistake. You have one chance of getting it right, so you should be there. So beautiful pictures of the pulmonary artery, lovely pictures of the pulmonary veins in a tiny baby with a heart rate of almost 200. So when you're looking at cardiac imaging, the choices, we've talked about non-gated versus ECG-gated retrospective gating and prospective gating. So remember, as I've said to you, the dose penalty, at least 2.5 times more effective dose for the exquisite pictures you get in retrospective gated scans. And if you look at the three-dimensional volume-rendered tomograms, 3-month-old child, quite low dose, under a millisievert, nice pictures. You can see the cardiac structure without any gating. If you look at the retrospectively gated scan, and this is a VRT in a child with a heart rate of 150, 2.7 millisieverts, but exquisite anatomy. You can see the trabeculation of the right ventricle very beautifully, and I'll show you the axial data sets to show you the difference in the image quality and line pair resolution. But prospectively gated scans, very beautiful anatomy, very nice line pair resolution, and also very low dose with a heart rate of 140. So a very attractive option. If you look at the axial data sets on that patients that we've just shown you, the same 3 patients. This is an axial data set in the patient who had the retrospectively gated scan, and you can see beautiful anatomy of the aortic valve cusps. You can actually see the cusps. You can also see exquisite anatomy of the pulmonary veins. And pulmonary veins are very elusive. They're very difficult to see in tiny children and also very important. Pulmonary vein stenosis is a very unpleasant condition and very important to know about. So 2 millisieverts gives you this sort of quality. If you look at the prospectively gated scans, you can still see the origin of the coronary arteries, so you can't see the valve cusps, but you've got quite a crisp picture with a much lower effective dose. The non-gated scans, really not very beautiful. You're not going to make any comment on coronaries or small vascular structures, so really workhorse, but not beautiful. And to reiterate the beauty of the retrospectively gated scan, again, you can see the origin of the coronary arteries, very crisp, valve cusp, beautiful aortic, beautiful wall detail at the right and left ventricles. And prospectively gated, again, nice pictures. Non-gated, not so nice, very blurry. So I would say if you do a lot of thoracic imaging, you should be thinking about prospectively gated scans as your default position for thoracic imaging where you want to have vascular anatomy. This is an example. The attractive feature of retrospective gating is not the better resolution alone. You also get temporally resolved data. You get systolic and diastolic images. And what you can do, if you're clever, is switch off your dose or switch it to very, very low acquisition rates during systole. And what it does is gives you very noisy images. You can see the systolic phase. You get this very blurry picture because you're only giving 4% of your total MAS at that time. So you're tricking the machine, essentially. You're getting temporary resolved data, but you're acquiring it mostly through diastole when the heart is stiller. And you will get this noisy data, but it does give you beautiful time-resolved data sets, and you can see motion. And we'll show how that can be used very nicely looking at things like vascular stents. Important to know about artifacts. If you have a child who's irritable, the acquisition of a prospectively gated scan is significantly longer on my machine. In a small child, a retrospectively gated data set through the thorax takes about 3 seconds, 2 seconds, whereas the prospective data sets in a bigger child would be 10 to 12 seconds. So movement artifact gives you this step artifact, very, very easily recognized. The good news is the axial data through those blocks, the step and shoot blocks, is very, very crisp. So you'll get very good axial images, so it doesn't really matter that there's been motion, but when you stitch them together, you will get the step artifact. And this is an interesting tiny baby who has scimitar syndrome. You can see the scimitar vein, partial anomalous pulmonary venous return into the back of the inferior vena cava, then into the left ventricle, and also has a horseshoe fused lung. So again, very important to look at the pulmonary anatomy when you're doing cardiac CT, and you give great added value as a radiologist. So when do you want to use cardiac CT? Well, we all know about justification. You have to justify why you're doing it, thinking about risk-benefit, thinking about what other tests you could do instead that may be safer for the child. Also, you are obliged to optimize your scanner. So you have to justify the examination, and then you follow that on with trying to make the best out of your machine, trying to get the best possible pictures at the lowest possible dose. When we did our first set of data, when we first started doing cardiac CT back in 2003, we did a very stiff audit on the first 445 patients, and we broke down why we were doing it. 30% or more, just a little bit more, were complex congenital heart disease, multiple abnormalities, and some of them not fitting any particular pattern. Great vessel pathology was just under 20%, mixed pulmonary arterial and venous abnormalities, patients with airway pathology associated, valvular disease, not very many at all, other miscellaneous, and coronary artery calcification in patients on hemodialysis. So let's have a look at some examples of the cases that we actually have seen. This is an example of a balanced double aortic arch. Normally, as you know, the right-sided arch is the dominant arch. It's slightly more unusual to get the balanced arch where the arches are the same size on the right and the left. It's important to tell the surgeon where the dominant arch is because they have to decide which side to do a thoracotomy. If you have a dominant right arch, they will take the left arch down and they will do a left-sided thoracotomy. In this case, it's a balance, so they can choose. It doesn't really matter. But you get wonderful information. You get very nice axial MIPS where you see the right and the left arch. You see this tiny trachea. You see the nasogastric tube in the esophagus. You can see on the coronal reformat, again, the narrowing of the trachea in all planes. You can get a virtual bronchogram where you can see the branching anatomy. Sometimes these patients have tracheobronchial abnormalities. And you get very nice volume-rendered tomograms, very useful for surgical mapping and also useful for speaking to parents. And sometimes the older children are very interested to see what their problems are. And they can understand in 3D much better than in 2D. So really, one of the benefits, the great benefits of CT scanning in the chest is the combined artery and airway abnormalities. So when you've got both sets, MRI still isn't really there yet for airway anatomy. This is an example of a child who has a pulmonary sling. You can see the pulmonary artery and you can see the pulmonary sling round the back of the tiny trachea. So really severe tracheal stenosis. In the same patient, you can see the axial soft tissue data, you can see the axial data on lung windows, and you can see here how important it is when you have this valuable data set that you do the proper reconstruction. If you have a soft tissue algorithm on lung windows, the lungs look disgusting. If you then reconstruct properly on a high-resolution bony algorithm, you can see the exquisite detail in the anatomy. And it's really important to remember that you must always manipulate your data set to get optimal lung windows. The other nice thing is you get these volume-rendered tomograms, and you can see this is a child who had a traditional bronchogram under general anesthesia, contrast into the trachea, and you can see this very abnormal stovepipe trachea, long segment tracheal stenosis, little apical attempt at an accessory bronchus, not quite making it, and this very narrow origin of right and left main bronchus. And this was associated with the pulmonary sling. The prognosis for this child is much worse with associated abnormal tracheal anatomy than it is with pulmonary sling alone. And there is a significant link between the two. It's absolutely vital the surgeon knows this before he goes in to operate, because correcting the pulmonary sling will not help this trachea, which is really compromised. Pulmonary hypertension is a fascinating subject, quite rare but lethal. It's that the prognosis of pulmonary arterial hypertension in children is worse than the worst cancers, and the Kaplan-Meier survival curves are very poor. So it really is important that these children are diagnosed appropriately and treated appropriately. And really, we have CT right at the beginning, straight after an echo. All of these children will have a cardiac CT and a lung CT. Why? Well, the list of abnormalities that are associated with pulmonary hypertension are shown, and we'll go through some of them. One of the most important, but one of the very rare associations is pulmonary veno-occlusive disease. And the reason it's important for radiologists to know about it is if you see a patient with pulmonary arterial hypertension diagnosed, you must exclude this type, this subtype, because treating with conventional therapy is lethal. The pressures drop and the child very, very sick. So it really is important that you know what it looks like. All of the other things like patients who have airways and interstitial disease as a cause for the pulmonary hypertension will be shown. Patients who have pulmonary emboli as an association, as a complication and as a cause. And patients who have vascular malformations in the lungs that may be causing their shunting and pulmonary hypertension. Also important to remember that big pulmonary arteries will squash your tracheobronchial tree and cause real problems with airway anatomy. One of the causes of pulmonary hypertension is the persistent fetal state where instead of having systemic and pulmonary circulation converting to a more normal neonatal period, vasodilatation phase, which is what happens in normal infants, you get this very sort of thick-walled vessel which then dilates up, becomes thinner-walled, and that's a normal phenomenon, and that's normal pulmonary pressure. In some children who have persistent pulmonary hypertension of the newborn, that doesn't happen, and instead of the vessels dilating and relaxing and pressures dropping, these vessels get thicker and thicker and thicker, and you get dreadful pulmonary arterial hypertension with persistent vasoconstriction and very thick wall. In an attempt to overcome what happens to the pulmonary vascular channels is you get thicker and thicker vessels, blood can't get through, you can see this blockage, you get turbulence, and then you get these little accessory vessels developing out the sides like bunches of grapes, and they're called plexiform lesions. So as you can't get, it's like a traffic jam, blood can't go forward, it has to go around, and you get these thin-walled plexiform lesions which are very abnormal, don't have the normal intimal structure of a pulmonary vessel and bleed very easily. And that gives you very interesting pictures on CT. You get these little patchy ground glass nodules. You get very abnormal arborization. You can see the branching of this pulmonary vessel. You never see 90-degree branching in a normal pulmonary artery. So you see abnormal arborization. And these little ground glass nodules are cholesterol granulometer and hemorrhage. This is a patient who has severe pulmonary arterial hypertension, huge pulmonary arteries, very easy to see, pruning peripherally, and again these very abnormal arborizations, 90-degree branches, really not normal. The other thing you often see is systemic collateralization. You get systemic vessels from the aorta. Any patient who's hypoxic will attempt to parasitize systemic blood into their lungs in order to increase oxygenation. And remember, these vessels are at systemic pressure, so that exacerbates the pressure because you've got systemic pressure blood going into a system where it shouldn't be going. So all of that is really important for surgeons to know about, especially if they're going to do transplantation. If you have a patient who has pulmonary hypertension and you want to monitor them, they're on therapy, you can actually put a value onto the abnormalities of their pulmonary vascular disease. And one of the ways to do that, some of you will remember from your maths when you're younger, looking at fractal curves. These are self-repeating patterns, and each is a little miniature copy of the whole. And the Mandelbrot set is probably the most famous, but the cauliflower, as you can see here, is another. And you can use these fractal dimensions looking at the ratio of change in detail to the change in scale. And that basically just gives you a numerical value for complexity of branching pattern. So if you have a straight line, your fractal dimension will be 1. So straight line is 1, curvature, you can measure the curvature and you can give a value. So what you do is you do a scan and then you apply the mathematical model, you threshold the pulmonary arteries and you have either region growing or center line, and you can see you can follow those branching vessels and you can monitor them over time. You can actually do a template and see how the patient changes with therapy over time. We actually looked at a group of patients which we published in 2011 using fractal dimensions to try and quantify their response to therapy and also predict survival. And that's very helpful in terms of families and management. And you can see here a normal patient with normal fractal dimensions of 1.7 and a very abnormal pulmonary arterial hypertension fractal dimension of 1.3. The consequences of having big pulmonary vessels or even abnormal aortic structure is compression of the tracheobronchial tree. And you can see here a patient who has a very significant, almost occlusion of the right bronchus because of these big dilated pulmonary arteries. This is another very extreme example of a patient with huge aneurysmal pulmonary arteries, and you can see the trachea, which is etched in green, and the tracheobronchial tree, how abnormal and how significant that will be in terms of patient morbidity. It's a real problem, and how to deal with this is very, very complicated. So a few more examples before we finish. We have 2 or 3 minutes left. Very interesting condition of pulmonary veno-occlusive disease. If you see it, you'll recognize it. In patients with sudden onset of severe pulmonary arterial hypertension, huge dilated pulmonary arteries, and the combination of these very smooth interlobular septal changes with mediastinal lymphadenopathy. Those three things together should worry you for the presence of pulmonary veno-occlusive disease. So it's not the big veins, it's the little veins that are affected. And you see the most beautiful interlobular septal change in these patients. You can see the secondary pulmonary lobules. And why are you seeing them? Well, if you remember your anatomy, secondary pulmonary lobular unit, central bronchus, and central pulmonary artery, and around the outside your pulmonary veins. And these are occluded in this disease, and that's the cause. So pulmonary veno-occlusive disease, unusual but really important. Combination of smooth interlobular septal thickening, diffuse multifocal changes of pulmonary vascular disease, and mediastinal adenopathy. Very important treatment, different to all of the other types of pulmonary hypertension. And most of the patients you'll see in pediatrics are idiopathic and genetic, but lots of conditions predisposed to pulmonary veno-occlusive disease. If you are interested, there are many papers talking about this complication of therapy and congenital problem. Surgically accessible thrombus, very important in patients, particularly post-operative. This is a patient with a Glenn shunt who has a catheter straight into the superior vena cava, which is anastomosed directly to the pulmonary arteries, and you can see this occlusive thrombus sitting here, which was surgically removed. Another patient with more peripheral embolus sitting in the pulmonary vasculature, very beautifully shown on this coronal image and histological sort of section of how that would look. Interstitial lung disease, a very rare cause of pulmonary arterial hypertension, but certainly does happen in patients with very advanced disease. And you can see these very dilated branched pulmonary arteries in a patient with peripheral paraseptal ground glass change, with little cystic changes in a patient with non-specific interstitial pneumonitis and connective tissue disease. Patients with premature lungs, parenchymal lung disease, bronchopulmonary dysplasia, very classic example, areas of atelectasis, areas of overinflation, distorting parenchymal bands through the lungs with pulmonary arterial hypertension, very commonly associated as a sort of syndrome together. Pulmonary vein stenosis, we really underestimate pulmonary vein stenosis. In premature babies, we are seeing quite a lot of patients with pulmonary venous stenosis. And you can see here uphill dilatation of the vein, very narrow area just adjacent to the insertion into the left atrium. This is another patient who, very interesting, had an echocardiogram for systolic function. It was a patient who was on chemotherapy for cancer. And you can see the right pulmonary artery very, very narrow, and you can see no pulmonary veins going into the back of the left atrium. So the pulmonary veins are all occluded by this big soft tissue mass. And this was a prospectively gated scan, which very nicely shows you, if you look at the back of the heart, you can see tiny pulmonary artery, nothing coming back, hardly anything going into the lung. And this patient had a fungal infection, Aspergillus infection, which was angioinvasive, invading the lung, and they basically switched off all perfusion to that lung, and the lung is now non-functional. Calcium and metal, very beautiful images, three-dimensional reconstruction of a patient with aortic coarctation, which has been surgically treated, which has been treated with a metallic stent. Very nice images of the stent. Another patient who has a fracture through the middle of their aortic stent, who subsequently was symptomatic again, and we did the CT without contrast, and you can see a fracture through the center of the metal. Many patients that we have with Fallot's tetralogy have percutaneous pulmonary valve stents, and those are very nicely shown. You can see this patient, beautiful image showing you collapse and fracture of the valve stent in systole. And you can see the metal fatigue is showing you where the stent is no longer functioning. The only last thing I'd like to say is the other very useful application of cardiac CT is in patients with major aortopulmonary collateral arteries. And the reason we need to do CT is to show the surgeon where the blood is coming to the lungs from these big MAPCAs, as we call them, and to assess what the native pulmonary arteries look like. And you can see very nicely right-sided aorta, big aortopulmonary collateral going to the left and one coming across into the right lung. And what you need to do there is get the surgeon to unifocalize, get them all together and try and create an insertion into the native pulmonary arteries if they're present. So basically, to conclude, think about CT, think about being a team, thinking about doing MR and CT as complementary, work together with your cardiologist. Remember the patients, we shouldn't be fighting, we should be helping them, and I hope we've done. Thank you.